So, good afternoon, everyone. I am Dr. Soumya. I welcome you all to our 18th IC InnovatorCLUB Virtual Meeting. Today's theme is tackling antimicrobial resistance, a multidisciplinary approach. Antimicrobial resistance is one of the most pressing public health challenges of our time, and it demands innovative solution across policy, diagnostic, education, and activity. We have a distinguished lineup of speakers and panelists who will share their insight and experience with us. So without further ado, I would like to invite Mr. Sachin Gaur to deliver a welcome note and set the tone for today's discussion. Mr. Sachin, the floor is yours.
Thanks, Dr. Soumya. It's a pleasure for me to be here and part of this August gathering. And I'm very happy to also see that we are approaching this topic in a multidisciplinary way. We will hear, from researchers, from practitioners, and also a legal angle to it, which I'm quite curious about. And my experience about AMR is limited. First time I learned about it was in Finland when I was in a conference and they were talking about a patient zero, where a Finnish person must have come to India, must have caught some kind of a fever. And when the person goes back to Finland, they didn't have the medicine to treat the fever. Because in a country like Finland, they control what kind of medicine is sold nationally. And apparently, the infection that the person had was stronger than the antibiotics available. So they have to change the medicine protocol at the national level to treat this person. This was some 6-7 years ago that I recall that I was there in this conference. Of course, since then, we have approached this topic a number of times at the InnovatorCLUB platform. Last year, we also had a workshop with the Swedish Embassy in the EU umbrella, where we had number of actors there, number of people present. And it seems like while the awareness of AMR is growing, but it is one of those topics in healthcare where maybe we are waiting for something big to happen to react. And my request to the experts here today, if you can guide us that what would we need to do that we can actually move from a reactionary approach to something proactive, because everybody knows what AMR is, or at least in the circles that we operate, but we don't see a wider action. And that is my kind of consideration to you. If you could tell us the way forward, that how we can approach this topic. So I would not like to take a lot of valuable time, and I think you as experts have much more to share. So thanks, Dr. Soumya, for collecting a great amount of expertise in form of this program today. And when it is, recorded and shared further, I hope it will create wider public awareness and some call to action. Thanks again for the experts joining today. We are grateful to you for enriching, ourselves and others with this important topic. Thanks, Dr. Soumya. Over to you.
Definitely, sir. Thank you, sir, for the insightful introduction. Now it's my pleasure to introduce our first keynote speaker, Ms. Jasmine. Ms. Jasmine is a seasoned researcher with extensive experience in AMR, data management and analysis. She's currently pursuing her PhD in computational biology at IITD and has also contributed significantly to various national health programs. Please join me in welcoming Ms. Jasmine. Ms. Jasmine, you can start your presentation.
So, good afternoon, everyone. I am delighted to be here today to discuss a pressing issue in public health, which is antimicrobial resistance. My name is Jasmine, and I work at the Division of Biomedical Informatics at ICMR. And I'm also a PhD researcher at the Department of Computational Biology and the Center of Excellence in Healthcare at IIIT Delhi. Today, we'll explore the challenges of AMR and consider some innovative solutions through a multidisciplinary approach. So, starting with the basics, so what is AMR? Basically, what happens is when our body gets exposed to a bacteria, the bacteria multiplies inside the body and we get infected. Once we take a medicine, the bacteria dies and the person is healthy again. However, in case of drug resistant bacteria, after getting infected, even after taking the antibiotic, the bacteria continues to spread and the person remains sick. So, in short, antimicrobial resistance is a phenomena when the bacteria, viruses, fungi, they no longer respond to the medications that were previously effective against them. This results in infections that are harder to treat, leading to increased disease spread, severity, and consequently mortality. As per the global burden of AMR study, in 2019 alone, AMR was associated with approximately 4.95 million deaths globally. This stark number underscores the need for effective action and an innovative solution. So now we know the problem. What can we actually do? So our fight against AMR should be at multiple fronts. Firstly, a simple solution is developing new antibiotics. This is a crucial solution, but is very challenging due to the scientific, regulatory, and financially hurdles. Developing a new antibiotic requires time and is very costly. A cost effective approach is optimizing the use of existing antibiotics through surveillance of resistance. We must therefore focus on preventive measures, including infection control, vaccination, and public education to reduce the spread of resistant infections. So basically, from a data perspective, addressing this challenge of AMR presents a complex challenge characterized by three significant gaps. So first major challenge is the siloed data sets. Basically, the AMR data is often segregated between different healthcare systems, laboratories, research institutions, which I'll be showing you in the consecutive slides. So this distinguished data sets, this hinders our ability to achieve a holistic view of the AMR of the country and conduct comprehensive analysis. So to tackle AMR effectively, it is important that we have systems that can integrate data across these diverse data sets, allowing for a seamless analysis and consequently policy decisions through these data. The second challenge that we have is lack of technical innovations in the public domain. There are a lot of innovative solutions available. However, those are either not usable in a low LMIC like India or are not available free to use in a public domain. So while many private entities have also developed solutions, these are not accessible to researchers due to sometimes costs or other barriers. So therefore, promoting open source frameworks or tools that can integrate diverse data sets and project nationwide pictures is essential. And the third and the most important gap is in the implementation. Even if we have the right tools, the integrated data systems, there is often a lag in implementation at the ground level. In my further slides, I will show you about a lot of data systems that are of surveillance systems that are currently operating in India. However, not many of them have their footfall at the ground or the community level. So this is what I'm trying to talk about through gaps in implementation. So to overcome these challenges, it is imperative that we foster a culture of collaboration, innovation, leveraging technology to break down these data silos and democratize access to cutting edge tools and streamline the implementation of effective AMR surveillance. So moving to the data sources in India. So I've put a picture of a lot of surveillance systems that are currently going on in India. So at the national level, There are basically three major surveillance systems. One is the NARSnet, which is the NCDC's national AMR surveillance system, which contains around 40 hospitals as a part of this network. The second major one is the ICMR's AMR surveillance network, which encompasses 31 sites across India. Then the third one, is there anything that anyone wants to speak? Hello?
No, please go ahead.
Okay. So the third one is the HAI surveillance system, which has 26 sites, which is monitoring the data from 26 sites across the country. So apart these at the national level, there are more systems like the MAHASAR, which is the Maharashtra State Antimicrobial Resistance Surveillance Network. We have a similar one for Kerala. We have, apart this, we have many surveillance systems across different laboratories, tertiary care hospitals across the country. So integrating and interpreting AMR data from these diverse healthcare settings is the biggest challenge. There is variability, quality issues, accessibility issues that can impede effective surveillance. So first of all, efforts should be made to standardize the data collection across the country and improve sharing between entities, which is crucial for developing a cohesive response to AMR. So the second challenge that we have is an innovative solution. So I'll be talking about the tools for collecting the surveillance data. So based on the features, this is one of my study that I'll be talking about. Based on the features, the tools, the existing available tools can be divided into two broad categories. One is collectors and others are integrators. Collectors are basically tools that are designed to capture a data at a small level. So basically they take data from small hospitals and they're easily installable, customizable, and are designed with a view to collect extensive data, like they have more data fields. However, they are not capable of projecting nationwide pictures. So one of the most common example for collectors is WHONET, if anyone knows about it. WHONET is a system that is developed by WHO. So it is a standalone system that can be installed on your computer and can capture AMR data for the lab that you're working and can give insights. However, you cannot integrate two WHONET devices to give insights for a country level. So the next that we have are integrators. Integrators are basically employed to capture a subset of data across different sites to give a holistic picture of the country. So what we actually require is a hybrid system that combines the capabilities of both collectors and integrators. The system should be capable of taking information at a level of granularity and also capable of projecting the nationwide estimates. So coming back to the qualities of an ideal AMR surveillance system. So I just talked about the challenges. The challenges basically are diversity in the data sources and formats and the limited public domain tools for capturing the AMR resistance and consumption. Our proposed solution here should be an interoperable, standardized, federated framework that should be configurable, expandable across different geographies. So if we make a tool for India, that should be capable of implementation in other nations across the globe. It should be flexible, but it should enforce a core data set that should be able to give nationwide projections. There should be a solution for integrated data analysis, standardization of molecular surveillance, and standards for data sharing. So, considering the qualities of an ideal surveillance system, we at Indian Council of Medical Research developed tools that could capture data from small laboratories to show nationwide estimates. So we have three tools. First is the IMRSS, which is a web-based tool that can capture data from tertiary care centers across the country. So it's a login-based tool and has a fixed set of data fields which can be used by any center with a working internet connection to share their AMR data. Now, for sites that do not have a good working AMR internet connection readily available, we have a data import application which can take in the data through LIS and HIS. So, if you have Excel based data, this can be fed into a one-stop AMR repository through the data import application. We also have a tool similar to WhoNet that can work on standalone systems, collect the data through the standalone systems, and share it to the one-stop AMR repository through the data import applications. And then one-stop AMR data repository can be used to give insights to stakeholders for the guidelines, policy recommendations, and so on. So using all these tools, we have collected more than 6 lakh patient records since October 2016 across 31 sites in the country. This data has been published as is being regularly published as annual reports. There are standard operating protocols released for laboratories based on this data, and this data is also used to formulate treatment guidelines for antimicrobial use across the country. So now once we have been talking about three things. First was the data. First and foremost is the availability of data. Second we have is the availability of tools that can capture that data. Now, once the tools also have captured the data, we have the data in hand. What is the next step? The next step is AI-based insights from that data. So here I'll be talking about one of my recently published study, which is the emerging trends in antimicrobial resistance in bloodstream infections. So this study is recently published in Lancet Southeast Asia. Here we use the data from the multicentric AMST data from the ICMR AMR surveillance network to project the trends of resistance to identify lead lag or indicator antibiotics. These were the antibiotics that could predict the emerging resistance in other antibiotics ahead of time. We could also identify the spillover of resistance from the communities to the hospitals. We worked to identify spatial clusters of AMR. And finally, we quantified the impact of AMR on the sustainable development goals through a data-driven Bayesian network model. So first of all, talking about the trends, we presented that through the data, we presented trends of resistance for each antibiotic microorganism combination. These were cluster robust trends catering to the heteroscedasticity and autocorrelation between the clusters. So so basically, we considered the clustering of resistances within the tertiary care centers, and that is how we analyzed the trends. Using the trends, we gave a AMR scorecard that could be used by hospitals to give actionable insights. So basically, on the right hand side, you see this figure with 4 quadrants, 1, 2, 3, 4. Basically, we could project the hospitals based on their rate of increase of resistance as well as the initial resistance levels into these 4 quadrants. The quadrants were divided based on the national average intercept and slope. So the quadrant 1 presents the hospitals with a favorable AMR profiles, the hospitals having low initial rate of resistance as well as low rate of increase of resistance. So we are showing through the arrows a path to containment of AMR. The hospitals in quadrant 3 can reduce their resistance level, come to quadrant 4 and consequently to quadrant 1. So basically, this scorecard can give actionable insights. This is what we are proposing to be implemented in the ICMR surveillance network for hospitals to gain insights into their resistance level through the routinely entered surveillance data. Then we are talking about the lead lag analysis for indicator antibiotics and CAHA-BSI associations. So basically, indicator antibiotics are antibiotics, something that we've proposed, that antibiotics that could predict the increasing resistance in other antibiotics ahead of time. So this we are doing through a lead lag analysis. In this figure that is presented on the screen, we are trying to see if there is any spillover of resistance from the community to the hospitals or from the hospitals to the community. So for the example that I have presented on the screen shows that for Escherichia coli BSIs in amikacin and piperacillin tazobactam, you can see these lines here. The resistance in hospital acquired bloodstream infections is leading the resistance in community acquired bloodstream infections for these two antibiotics. We have certain examples wherein we see a leading relationship from chi to high as well. So lastly, I want to talk about the quantification of association between AMR and the Sustainable Development Goals. So Sustainable Development Goals are basically a set of goals that talk about a sustainable future by 2050. These are a set of 17 goals that have been set by the United Nations. And in India, its implementation is being overseen by the Niti Aayog. So we took the baseline SDG data for every state from the Niti Aayog report and tried to study this in context of the AMR resistance levels that were presented from the sites. We see an association between the imipenem resistance and the Sustainable Development Goal 3, which is the goal for good health and well-being, wherein we see the states through this bar chart. You can see aspirants are states which are faring low in their SDG levels. So states with low high resistance are basically performing low in the SDG goals, or like vice versa. So basically we want to say that AMR and SDGs are interlinked, and if we want to progress towards the sustainable development goals, we should consider antimicrobial resistance as an important aspect. Just a second. Slide stop moving. My slide stopped moving. Yeah, so a big thank you for everyone who came for this webinar. And thanks to my mentors, Dr. Taprate Sethi from IIIT Delhi and Dr. Harpreet Singh from ICMR. So in conclusion, I would just like to say that AMR is a multifaceted phenomena. And to tackle this, we need a multidisciplinary approach that should involve collaboration between researchers, public health professionals, policymakers, as well as people as a community. We all should come together and have play our role in fight against AMR, because this is brewing as the next pandemic, and if untackled, this can take a lot of lives. Thank you.
Thank you, Ms. Jasmine Kaur, for that enlightening note. So, moving on, our next keynote speaker is Advocate Robin Majumdar. Advocate Majumdar is an advocate on record at the Supreme Court of India with a profound interest in AMR, environmental and hospital-related cases. He brings a unique legal perspective to our discussion. Please welcome Advocate Robin Majumdar. Over to you, sir.
Thank you, Dr. Soumya. My previous speaker, Miss Jasmine Kaur, she mentioned in the last that yes, so many are the participants, they should in tandem work. But she did not mention the advocate's name, who was an important component of the society which helps regulation to be in order.
Really sorry about that, sir.
On a lighter note, that was, please do not take it otherwise. Okay, my today's topic is one health, one law, and one environment. Let me prepare that. Let me share the screen. Yeah. Can everyone see that?
Yes, sir.
Is this okay? It is visible to screen to everyone? Hello, I can't hear anyone of you.
Yes, sir.
Okay, fine. Let me go ahead. The mission for the environmental lawyer is always one, that is one health, one law, and one environment. So on the part of the legal dimensions of the AMR, let me see how it should be brought down. Yeah, okay. In this, everyone today knows what AMR is, more or less non-scientific background, science background, and doctors, healthcare professionals, everyone knows, right? But one important thing in the introductory note, I need to tell you about the third paragraph. If you see that WHO has determined AMR as a global health and developmental threat. So in that case, it's a seriousness that concerns all of us, including the superbugs theory. And what is the quantum of the pharmaceutical manufacturing country that they produce the pharmas all throughout the world, led by USA, of course. Second is China. USA's volume is 51,666 CR in Indian rupee, in dollar. In dollar terms. India is the last but one, but yes, nevertheless, it has 4,356 crore dollar. So that is what the volume of pharmaceutical produce in terms of commerce it is. And that the volume of the seriousness also that should encompass any of us, all of us. And India particularly, which we are the top of the world in exporting the generic drugs. And Germany, of course, they do a lot of patented pharmaceuticals. To postulate what we received today is this global threats calls for global response, and we should, and together we can prevent the AMR. That is with the hope that we start the discussion on the legal side of it. Now, if we quickly see how the world level the AMR is being seen as on the legal perspective is starting with the WHO. In 2014 itself, they had prepared a draft global action plan on AMR. UK has its own 5-year national action plan. So is for USA, so is for India, and so is for EC also. But all these countries, including the monitor is called WHO, has a policymakers, but they do not have interstate or inter-country cooperation. That lack of global coordination is apparent, and that is why still it is the country-specific phenomena. Although it is not as such. Why? Because if we see, kindly see the sixth paragraph, where you see that after China, India is a sizable share of production of active pharmaceuticals ingredient, that is API, besides processing of drugs. Pharmaceutical industry is involved in manufacture of API and formulations may discharge effluents that contain antibiotic residues into the environment, which may most likely and ultimately leads to contamination of surface water and the groundwater, which is, of course, the source of drinking water supply among the other users. Now, with this background, how we see, yes. Now, let us go to the next page, the page 4. This is an important one. As far as country is concerned, our India is concerned, the Department of Biotechnology under Government of India, in partnership with Research Council United Kingdom, that's RC UK, the strategic partnership of UK's 7 research councils, commissioned a study to map the AMR research landscapes mapping in India, and which apparently summarizes the current AMR situation in India and identifies the current research gaps to determine future research priorities in India. To that extent, the ICMR also is contributing a sizable research, but coordination is lacking between different departments, including the DPT, the ICMR, and then WHO, of course, and of course, Ministry of Health and Family Affairs, and Ministry of Environmental and Climate Change. These 5 bodies are very, very important component of changing the landscape of the AMR threat in India. Now, kindly see the Roman 5, Roman 4 one. Yeah. MOFC, Ministry of Environmental, Forest and Climate Change, by notification has brought down some notification, draft notification in 2020. And after that, it's all regarding the discharge of APIs in a different platforms, including the water bodies and antibiotic residues produced by the pharma companies at different parts of the country. Sorry. Then there is a concept came up in the international forum, and also it is rounding in the Indian legal circle and the policymakers, is also that smart regulation of antibiotic use in India. In this smart regulation concept, the understanding, innovating, and improving the compliance project are the first to better understand the various problems surrounding the regulation of AMR, containment in India, and second is important, that is to improve the situation by applying the concept and methods of smart regulation. This smart regulation concept is, of course, if you see the footnote, kindly see the footnote, and the 6th one. This is actually the Newton Bhabha Fund project funded by the UK Economic and Social Research Council, ESRC, and Government of India, Department of Biotechnology. This is a joint project, and this concept of smart regulation came into being, still under implementation. Now, while all these policies are in order, right and wrong, adequate or inadequate, that was another issue. A case came up before Honorable National Green Tribunal, supported by Dr. VNP Singh led Veterans Forum for Transparency in Public Life. I am the standing counsel for them in the NGT also and the Supreme Court of India also. So they did some private research, of course, with the limited resources that they have, because they do not take any, as I am told, they do not take any donation or any kind of support services or funding, etc. They did 2 research in one in Sirsha, another is in Baddi, and they found out the gross violation of the environmental laws, and there is no checks, no balances as far as APIs are concerned, and the residues are concerned, that antibiotic residues discharge is concerned. So they moved the NGT. NGT has been very active in all this AMR issue especially, and it has found out that it's a serious threat to human beings. And while the NGT matter was pending, the Government of India through MOEFCC has come out with the final notes, which you find out in Roman 6 on the page 4. The final notification was published almost 18 months later than GSR 6/8/2021, but did not include the standard of antibiotic discharge. Very, very serious issue. We talk a lot about science, a lot about laws, a lot about environment and all that. we all need to focus on the actual antibiotic discharge at the threshold level. That is where the pharmaceutical drug manufacturers companies are active upon. So final notes are there in order. Then the second one, which is very much when the final notes came, there was a murmur amongst the pharma companies and also some sort of state regulatory companies, state regulatory authorities, that all this research, all this monitoring requires an excess financial burden to the industry, and that may not be possible for a better regulation. But we all need to know that regulatory burden is a basic reality and the environment is no exception. So these two are very important things: the regulatory burden and also environmental causes. So there needs a balance. And while the balance is on, the final notes is in the order in the public domain. The Honorable NGT, the National Green Tribunal, came up with the final order on 6/4/2022, whereas it decided to take steps to provide relief until the government of India finalize the standard of antibiotic residues. So ultimately, we are coming back to the antibiotic residues in industrial effluents and the API standards. So the final notes issued by the MOE FCC is still silent. What should be the industrial standard, API standards, and what should be the antibiotic residues, how much, and what would be the treatment process? That is still silent. And that way, rampantly, that pollution is on, the health is on hazardal mode. So kindly see, I can share you the actual order of 6/4/2022 of the NGT and a later platform. No, but 15 and 16, if you can just work out to see little, it will help us understanding what is the consequence and also the order of the Honorable NGT. 15 and 16 is very important. At the cost of everybody's time, I need to read out this. The draft standards were formulated and notified on 23rd January 2020, more than 2 years ago. Based on the study by experts, regulatory mechanisms such important issues cannot remain in abeyance for indefinite period for the ground that MOEFCC is unable to finalize the draft standards even after 2 years. In view of the serious consequences of unregulated discharge of APIs residue to the detriment of environment and public health, we consider it appropriate to direct the under Section 15(1) of NGT Act that pending the finalization of MEFCC standards proposed in the draft notification dated 23rd January 2020, which are based on the expert studies, be strictly followed by all concerned. It is also necessary to abide by the guidelines of CPCB circulated on 31st January 22, quoted above in the matter of standards and methodology on the subject. The state PCBs may take further action accordingly to prevent and remedy the situation of unregulated discharge of the harmful pollutants of pharma industries in the rivers. So, very ironically, this order was challenged by Union of India before the Honorable Supreme Court, and I am the advocate on record on behalf of, as I said, the Veterans Forum for Transparency in Public Life, and the matter is still pending. Although Supreme Court has issued notice in this, it is a sub judice matter. We need not go in more deep into it. Now, let us see. Yes. Next is the Indian perspective, how we see the AMR in today's world, how far we are policy formulated so far to contain the situation, to avoid damaging the health of the public and all the environment as such generally. So implementation of Indian NAP for AMR is a well-designed comprehensive plan, has been noticeably slow, and a big push is needed by all stakeholders, government, pharma companies, healthcare professionals, and advocates et al. That's what I requested Jasmine to include the advocates also, because the environmental advocates also play a lot of role, including the scientists and healthcare professionals, and of course, pharma companies, their commercial interest is also there. And of course, under the umbrella of the government. Now, what do we need? See the para 4, Roman 4. The strong legal commitment and support from many of the public-private partnership are essential for successful implementation of the National Action Plan, what the Indian government has came out with. Then, of course, WHO and stakeholders should support the implementation of National Action Plan, because in a huge outlay of financial things is also involved. And their say also is necessary to be minding this thing situation. Okay. Then the last one in this is, we in India need to group 3 layers of granularity. That is one, governance areas, domains, and indicators to prevent more detailed findings for India's policymakers to identify the policy priorities. So policy priorities finding out and implementation is much more that is needed. And although the several studies are showing that the pharmaceutical pollution is a significant problem of ecosystem and human health, yet in India there is still no convincing sign of its strategic approach to pharmaceuticals in the environment, which was initially slated for publication in 2015, that in AP1. Then lastly in this sector is the AMR Industry Alliance, which is my research, and I find out that the largest private sector coalition of almost 100 biotech, diagnostic, generics, and research-based pharmaceutical companies and associations that aims to provide the sustainable solutions to curb the AMR has released standards for antibiotic residue. So, as a government of India and as a policymaker for the betterment of health and also the better future in the environment, we all need to take the everybody's expertise, including like AMR Industry Alliance, like Veteran Forum, like ICMR, or like DPT, and so on and so forth. Right, so that we have a better level playing field for everyone and also a sustainable environmental future for all of us. And then finally, the last one, I would say the B, yeah. Regulatory harmonization may speed antibiotic approvals and sign a government's commitment to increasing antibiotic research, antibiotic access, increasing antibiotic access. A comprehensive study is of course needed for a regulatory frameworks also and for otherwise also. Then that is why WHO, which came up with the 2017's NAP guidelines, which is under 94 member states, they are committed to object of having multi-sectoral NAP. So all those NOPs need to correlate and situationally applied. And of course, fund mechanism is also there. That also need to be looked into by the fundraisers and also WHO-like international authorities. Then lastly, 2 more things, and then I'm done with the things. I know there are other panelists in this block. Then finally, the pharmaceutical manufacturer should also fully participate in the development and data collection process of independent initiatives that increase the cooperation and the transparency and also diffusion of good practices. So good practices is also something which is missing both from the policy side also and also on the framework side also. And lastly, to resolve or at least substantially reduce the impact of AMR, we all need to try and explore a new WHO regulation under Article 21 of WHO's Constitution. And WHO Constitution is of 2005, and we all need to work together for a better and sustainable future. And the last but not the least, so let's better keep our one law, working for one health and one environment. thank you. I took a lot of time, and thanks for giving me opportunity to talk on this AMR issue on the law points. Over to the organizer.
Thank you, sir, for your comprehensive keynote. We now move on to our panel discussion, which will be moderated by Praveen sir, and joining him are three distinguished panelists. So, Dr. Ranga Reddy Bari is a globally recognized expert in AMR containment and a pioneer in infection prevention and control education. His work spans multiple continents and focuses on enhancing public health and infection prevention capabilities in low resource settings. Next, we have Dr. Sonal Saxena ma'am, a prominent microbiologist and educator, is the director professor in the Department of Microbiology at Maulana Azad Medical College. She has a strong commitment to education and research, particularly in antibiotic resistance detection and surveillance. Next, we have Dr. Vikas Ranjan, is the medical affairs manager at BioMarriott, where he oversees medical strategies for diagnostic solutions. With extensive experience in clinical microbiology, he has contributed significantly to national health programs and diagnostics. So, I will now hand over to Advocate Majumdar to lead the discussion.
Welcome, Dr. Ranga Reddy Buri. You have very impressive short biodata, which is more than shorter, right? But the short biodata which was handed to me during the course of the programs is that you have very good, rather very impressive presence in developing the postgraduate curriculum in infection prevention and control. It is unique, other than we all work for the AMR in the field, in the research room and all that. If I may ask you, how do you find that this curriculum on infection prevention and control in the academic pathways will help us a general awareness of the AMR and its issues amongst the student and amongst the people at large? If you can please highlight.
Thank you, Mr. Mazumdar. I had been very keenly listening to your fantastic presentation, actually touching upon those issues which are usually forgotten or not underlined, the environmental aspect of it. I think, my kudos and congratulations for bringing that particular invisible topic. Like antimicrobial resistance, environmental aspect is also usually invisible to most of the people. And your effort to bring it out to this open forum, I am sure it is going to do a lot of good in terms of containing and fighting against the antimicrobial resistance. Thank you.
Thank you.
And thank you, InnovatorCLUB, for having me today and having the stage shared with such prominent people who are doing a good job in terms of actually AMR containment. Now, coming back to the question by Mr. Mazumdar, we all know that
on a lighter note, I cannot question you. I can place my query to you. Yeah.
Thank you. So, if we actually flip back, why does the resistance happen? The resistance happens because we are not preventing. So, unless there is going to be a large work which is going to be done in terms of preventing the infections, we will never be able to overcome the problem of antimicrobial resistance. Because invariably, if there is an infection, that means you had to intervene. You had to treat it some other way. And while treating, we may most of the times, because of the lack of laboratory infrastructure, diagnostic infrastructure, a lack of the knowledge, a lack of actually, many other things like infrastructure, we may misuse, overuse, or sometimes, we may be not choosing the optimal treatment in order to ensure that while we are going to provide a succor to the patient, we are not going to be the perpetrator of a larger problem called as resistance. That is why, Mr. Mazumdar, it is very, very important laying a very strong foundation of hygiene, of prevention is very, very important, and ensuring that institutionalizing such efforts is the most important aspect. If you look at, you talked about the national action plans for the containment of antimicrobial resistance. Either you look at the global action plans or the national action plans, are equally important, that is the state action plans or the sub-national action plans. You would see one of the major pillars, either 5 in the global action plan or 6 in our national action plan or 6 or 7 in our some of the state action plans, you would see one of the major pillars is infection prevention and control, right? And it is talked about a lot, but in reality, we don't have the workforce or the experts or the specialists who are supposed to be dealing with this. We have minuscule of them. They are not formally trained. Usually people who are called as infection preventionists, I am talking about now specifically the human healthcare segment. You would have infection control officers and infection control nurses who are like the core of actually infection prevention. But do we have any training? I don't think. Neither at a MBBS curriculum, nor at the nursing curriculum, or at a postgraduate medical education curriculum, we don't have a very specialized kind of education given, training and education given. And of course, the new CBME has some components of infection prevention and control, but still it is far away from the needs of the society in order to deal with this problem. That is why in 2018, we have come with this specific curriculum, especially for those countries which are so-called resource-limited settings or resource-limited countries. In those countries, the problems are different from the resource-rich countries, or we call them as global north countries or the developed countries. And hence, we thought we need to prepare a curriculum and prepare the workforce, or we call it as preparing actually the capacity of the workforce in order to effectively deal with not only AMR but also the pandemics which have become such a big thing for us, arising very frequently than what we have seen a couple of decades back. COVID-19 is still in our memory very much, and we also are painfully aware that the disease X or the pandemic X is going to be just around the corner. So that means we need to build this capacity, and there is no substitute to prepare that kind of capacity other than having an academic curriculum through the universities offered and creating that kind of experts who are going to effectively safeguard the lives, billions and billions of lives on this planet. Thank you for the opportunity.
Yes, good. And I appreciate that you are the founder of Infection Control Academy of India. And perhaps this as a part of, as I said, the triple P method, right? It will help the academic cause also, and also ultimately the environmental cause. Thank you. Good input, and we appreciate. Thank you very much, Dr. Reddy. Now we have the second on the panel is Dr. Sonal Saxena. Sonal Saxena is the distinguished alumna of MAMC and also the Lady Hardinge Professor, Director Professor of Department of Microbiology. Is Dr. Sonal Saxena online? Yeah, have you joined, right? But we can't hear you, ma'am.
I'm there, sir.
Yes. Ma'am, you have impressive position that you are holding in different platform, especially on a personal note, that you have a lot of academic interest, which I also attracts me a lot. Academic interest, right? But how do you find there's a lot of time between the patient care and also the academic interest? Very difficult how doctors maintain these two different lifestyle professionally. Is very impressive. Ma'am, how do you see that the WHO is doing enough uh, to contain the AMR situation in India? Does it not it have enough control mechanism or at least policy mechanism to control the pharma industry as such, so that we in India should be safe, Indians should be safer, environmentalists should be safer? If you can have some words or some light on it. It's a different
Good
kind of,
afternoon.
but if you can.
Hello, good afternoon. And I have been working in antimicrobial resistance since my post-graduation thesis was on vancomycin resistant enterococcus. So since those days, I've been working on AMR only. And over the years, I have felt that the role of WHO or any other agency, NCDC, they have all risen to this call and they have done an exceptional work. Not just, in silos, they are doing many things together also. And before I answer your question specifically, I would like to place on record a pertinent thing which Ms. Jasmine Kaur missed. One of the antimicrobial resistance network is the Delhi State Network of Antimicrobial Resistance, for which I am the founder and the coordinator. Now, this group was founded in 2020. We have a group of 24 laboratories. And since from 2023, we are part of the NCDC network. So there are 3 state networks, Maharashtra, Kerala, and Delhi. And we are the largest out of all these, all the 3 networks. And we have data from 2020 to 2024 till now. It is continuing. Now, this network initially was established with the help of WHO. WHO and our IIMM Delhi chapter, particularly the Indian Association of Medical Microbiologists, we felt this need that the NCDC and ICMR networks are 2 different networks, but they are actually, if you look at the size of our country, they are very less. So we felt that each state should have a network. So WHO went and collaborated with in Maharashtra, in Kerala, and in Delhi, and we created these networks. And we shall forever remain thankful to that. But in 2023, NCDC took over these networks. So now we don't get any funding or support from WHO, but we get it from NCDC, and we are part of that same network which NCDC has. We submit our data regularly there. So WHO in its own way has helped. Now, we have to remember that WHO actually answers to the Ministry of Health in that particular country. So they work on the agenda which is outlined to them by the Ministry of Health of that particular nation. Only then the country office works on those lines. And WHO has been supporting NCDC, Ministry of Health, and associations. We've had multiple WHONET workshops because I myself have been involved in many of them as a trainer, and we've had a lot of support. When it comes to the pharma industry, I think there are more regulatory bodies which have to play a larger role here. Like I heard the environmentalist when he was talking about, and there are so many legal issues and that there are so many drug controller issues that I think those regulatory bodies have a larger role to play. And the implementation of those rules and implementation of those methodologies have to be more important than the WHO or UNICEF or anyone.
Yeah, that's right. It means science should be in the research room and law should be in the summer field, right? To give a composite work for the better environment, if I may say. And ma'am, the one more question and quick question, because we have another panelist also. Do you think that our policy, which has been explored through one is DBT research, ICMR, of course, and private bodies, and also the NAPs, National Action Plan, are enough for the purpose of present day situation to contain the situation? Because all these policies do not talk about the pharmaceutical API on the residues and all that. So you think it is enough or we need a little more strictly little
So
more.
I think with the action plan 2.0 going into a One Health approach,
Yeah.
they are likely to cover it up in that aspects. And now, as we are also increasing the education gambit for AMR, and we are also increasing the awareness part. AMR is now going to be a separate module also in for undergraduate teaching, and with all the other things changes being happening, I think this will also come up that the NAP 2.0 will take it up as a one thing.
That's good. So with this hope, we thank you. And our next panelist is, ma'am, thank you, ma'am, so much. Our next panelist is Dr. Vikas Ranjan. He is currently actually working as a medical affairs manager of BioMeriax, and which plays a pivotal role in overseeing the medical strategies and ensuring the efficacy of diagnostic solutions. And Dr. Vikas Ranjan has also contributed his expertise as a senior consultant in the concerned ministry, of course, the Ministry of Health and Family Welfare, and as a scientist C and also an ICMR. So, Dr. Vikas Ranjan, are you there? Yeah.
Yes, sir,
see.
I'm here.
Yeah,
Good
thank you.
evening.
Welcome on behalf of the organizer. They have given me onerous task of moderating this, which I am doing it for the first time in my life. Right, but I did not know how to do it, but I have done it. So, Dr. Vikas, you have 2-3 different kinds of focus in profession, right? I mean, another experience which is coming up from different focuses. One is that you are an academician also, and also you have a very good managerially active person in biomediacs, right? Biomediacs. And also you were associated with Ministry of Home and Family Welfare.
Yes, sir.
As a consultant, as a scientist. How do you see that the sitting in the boardroom, bureaucratic boardroom, will help the environmental issues concerning all of us to be in a more safer mode for a sustainable purposes?
First of all, thank you very much, sir, for giving me an opportunity to speak on this very important platform and a subject which is very much close to us, and sharing this platform with so many stalwart, Dr. Sonal Madam and Dr. Ranga Reddy, sir, and with you, and also thankful to hear all those important recent presentation. So first of all, coming to the profile where I worked in the Ministry of Health. See, it was actually how the draft policy was made, which all points were taken into coming to writing to the draft guideline. So that was the main issue. Many of the concerned ministries were involved, and many of the important stakeholders were involved. Even most of the hospitals, most of the ICMR institutes, and the institutes working on the background of AMR, they were also concerned with it. They were called upon, and they were asked certain questions. See, what next we have to do, where we are lacking. So this was all. It was a very nice learning experience for me, because I was not very much associated, but I was just associated for 4 or 5 months because I was doing my MBA. So I just wanted to look very close to it, how certain policies for a country like us is being made or drafted on a table, what all discussions goes on. So, but we do have a lot of challenges. Mostly the challenge lies about the education, and the second one is the prescription. These are the two major challenges what we see. Even though we educate, the prescriptions are not happening in that way, because many of the times what we see that in the urine culture report, we see plus, 2 plus, 3 plus, not any organism counts are mentioned. They're very problematic. Secondly, the identification of the organism are not mentioned, because identification is very much important related to AMR. Thirdly, over-the-counter drugs. What all drugs to be reported in any kind of a culture, whether they are followed upon with the existing guideline. For us, like it is CLSI. So is it practiced in the right way or not? So BioMerio as an institution in the BioMerio, we are pushing it regards to 2 platforms, the diagnostic stewardship and antimicrobial stewardship. So So these two things are the pillars of any for the challenge of the AMR diagnostic. What diagnostic test I should do first, and once I have the test done, I have the diagnosis. What antibiotics I have to start, depending upon these two things are very important. Education is very important too. Biomario is doing all such activities in the medical colleges, in the hospitals. We are doing the road shows. We are coming up with a lot of solutions which can provide the results in within maximum up to 6 hours. And now we have a solution. We can give you a result within 3 hours. See, this is not a platform where I will talk upon the solution, but there are solutions. Many companies are doing it, but the basic framework is to tackle the problem of AMR. So that's all from my side.
Okay. Dr. Shonal Saxena, if you are on, if you're still there. Okay. I see Dr. Rangareddy. Dr. Reddy, I have a specific question based on the three panelists. And it is very important that all doctors, scientists are there today. Dr. Reddy, how do you see that your academic journey, right? Academic journey to emancipate the knowledge sharing among the student will help the environmental awareness. Of course, very strictly and traditionally, it is a boardroom based scientist. I mean, it's like a laboratory based curriculum to an academic based situation, which has to see the sunlight on every moment. Dr. Sonal, I will be talking the same question.
Thank you.
Also a little later. Yes, Dr. Reddy.
Thank you very much. A very interesting but very tough question, because there are several policies, but it is the implementation which always had been a problem, right? So there is a lot of knowledge. It is not the knowledge, which is the problem today. It is actually putting that knowledge into the minds of those who are supposed to be implementing on the ground level, and also making a difference to this global health problem. I would approach your question a little differently, right? I would say that AMR now is everybody's problem. It is not just a health problem. It is a socio-economic problem. It is a cultural problem. And if we are going to allow this to escalate the way it is escalating today, I'm sure the humanity as we knew, right? And all the kind of, advances we made in every field, probably that would be undone very, very soon. So that's why, more than actually my work in the academics, my work is more on the, as a civil society activist. I am part of now, there is a global platform, which is called as a quadripartite platform. Very recently, we have prepared a very comprehensive document to be adopted by the UN General Assembly in September this year, right? As a result of actually our document, which we have produced with the effort of about 140 organizations across the world who are part of this platform, that is starting from World Health Organization to Infection Control Academy of India, for which I represent. We all made a significant effort to understand why, despite the knowledge available, despite the fact that we all understand this is a crisis, a crisis which is maybe many fold bigger than the COVID-19, why is that we are unable to make a significant progress in containing this problem? So that is the document which we have prepared. Now there is a draft political statement which has been published about a couple of days back by the UN General Assembly Secretariat, where very clearly the UN General Assembly is going to actually ask all its member countries in order to approach this problem with a one health attitude, right? Unless we are going to have this One Health at the center of finding a solution to this problem, we will not be able to deal with this multi-sectoral interdisciplinary problem. And you, the people like you who, at a first glance looks like, what a lawyer had to do with a problem which is purely medical. No, actually, as I said in the beginning itself, it is socio-economic, it is legal. You take any aspect and you take any of the SDG, right, which we were, pledged, which we all pledged actually to comply with by 2030. Of course, we are not going to meet those sustainable development goals currently, right? But if you look at the impact of AMR, there is no one probably SDG which is not going to be impacted. That's why, a lawyer, a teacher, a social worker, a doctor, a politician, we all have a very large role to play. So coming back and taking a cue from what you said, the academic kind of training which is given to the people, how it would reflect in terms of the outcomes for AMR containment. It is not only medical curriculum which had to be, which had to have this problem covered. It is even social studies students, who had to actually get trained in this aspect. At least, they had to be stimulated about it.
Exactly.
The lawyers, so that, the people like you can take up this issue and go to the Green Tribunal and ask actually to set the right kind of path in order to address the environmental issues.
Yeah.
Probably I would stay here and, because, there is a paucity of time. So let me stop here. Thank you.
Yeah, thank you. On a far better platform, we can have a far better talk. So because we have a constraint of time also, Dr. Reddy, exemplary explanation from your side, and we really thankful to you. Dr. Sunal Saxena, ma'am, almost the similar line questions. You have a large experience, both as a professional doctor and treating the patients, and also an academician. And also, we have been working with the WHO and also Sweden government. So, I'm told there is a very good AMR activist company in Sweden, I think, which is called, I don't remember at this moment. But Sweden, that company, that organization is very much active in AMR control and all that, research and everything. What is your perspective, ma'am, as an Indian citizen and also a professional doctor? What we should do to contain the situation? Based on your international exposure, if you please highlight something.
Yes. Actually, Mr. Vanidam, what I have felt during my interactions internationally is they have excellent IPC. Their infection prevention and control knowledge, their awareness, and their, even school children are aware about hand washing, about hand hygiene practices. So that is, prevention is always better than cure. So that kind of limits the infections that they have in their country. The second is their implementation of the law is very, very strict in Western countries as compared to us, although there are loopholes everywhere. And lastly, I feel the sheer burden of diseases and population base that we have to play to our strengths. We can't just blindly copy Europe, which has maybe, less number of people per square meter compared to what we have. And our problems, being a tropical country, are also very, very different. Secondly, our healthcare system is, it's still developing. It is not that you don't have culture facilities, you don't have antimicrobial testing facilities at the secondary or peripheral, leave the peripheral, even the secondary level. And even if you have it at a tertiary level, I collect the data from 24 laboratories. I find that there are multiple quality issues, multiple awareness issues. So even in the doctor's mindset, this is happening. So you can imagine what must be happening at the general public level. So we have to play to these trends and increase that awareness.
Yes, that's true. There's a very good important point that awareness as a policy formulation which is not available in this. But we need to do that. Thank you, ma'am. Thank you so much. And the last query from Dr. Ranjan. You are a scientist, boardroom scientist, which has a lot of exposure in the laboratories, right? Now you tell me, you must be working with the NCDC and also CDSCO, that is Central Drugs Standard Control Organization. We have these two parents watchdog in the AMR issues. If we
Yes, sir.
strictly point out that, are you sure that this antimicrobial stewardship, and as you pointed out that diagnostics stewardship, which has been actually propagated by ICMR, is good enough? I mean, or if it is good, to make it good enough, it needs to be implemented. How do you see this stewardship things needs to be implemented at a ground level, not remaining as a policy book kind of things?
Yes, sir. The important thing is that every hospital has a monthly meeting on their resistance, their antibiogram. What all antibiotics were taken were for the ICUs, for the normal wards, for then OPDs. The questions has to be put up at that point only. Why certain not? So there are many points given by many prevalent uh, doctors across the country that we should have an audit of the antibiotics. Not only the audits for the antibiotics, but also the pharmacy people also should sit in the audit. Why this particular antibiotic was prescribed? Was there any questions put up for the clinician? Why you had prescribed this medicine? What was the reason behind it? So this kind of audits are very much needed. First of all, second, check upon what any check means any frequent check means just like a point prevalence survey that we do. Any given day, we just go in and just see what kind of a madam has also said infection prevention control activity. So what we can also plan do a point prevalence survey. That is being done, but how much it is implemented, whether any action is taken for the point prevalence surveys, it gives you a snapshot of a whole day. It gives you a snapshot of a whole day, which you can incorporate for the rest of the year, what you are going to see for the whole of the year. Second thing. And the third thing is the education. Education. I mean, educating from the point, as Madam also said, from the student, people know about AMR from the schools. Now, we have some certain challenges. We can do it, but there are certain challenges. Who are going to teach about the AMR? Are they themselves are knowing about the problem of the AMR?
No, yeah,
and then coming to from the hospital perspective, from the point the students who are incorporated in the first year of MBBS to the day they go out of the hospital, in their course, is there any efficient IPC activities are being planned out for them? Is there it is in their curriculum? It is being implemented, but at what level? So these are the problems, and it is definitely attainable. We can attain the answers for the AMR. The only challenge is that how good the implementation on ground it is, and it's all in our hand. It's all in our hand.
Yeah. So that's what from all the talks by Dr. Rangareddy, then Dr. Shonal Saxena and Dr. Vikas Ranjan is that apart from the knowledge, we have to impart the understanding also amongst the people. People starts from the studentships and also the citizens at large. So on my take as a lawyer, I would say that surveillance, monitoring and regulatory frameworks is unfailingly needed as a multi-sectoral One Health, One Law program. And of course, then only one environment approach can be possible at every level, be it a boardroom or on the threshold of the ground. And this is only achievable when an integrated coordination network should be there. Public-private partnership mode, and also the main player is the pharma company. They also need to be casualed to be brought on this discussion one day. With this, thanks everyone, and I hand over this to the organizer, Dr.
Sir, Ravin sir, there is a question in the chat box. Can you address that question with our panel?
So just let
By
me.
Sarah.
Mm,
By Sarah. Sarah has asked a question.
okay. Yeah, there are a couple of things that has come in the chat box. Just a few seconds. A question to panel. That one. Finding new methods.
Yes, sir. How feasible
One
will
above it.
be if
One above it.
Above it. Okay. No, above it.
I can read out the question.
Yeah.
How feasible will be to incorporate smart regulations into existing regulations and legislation? Given the multifaceted nature of this problem, who are the central actors leading this sort of integration?
Yeah, exactly. I mean, that is the moot question. That is a moot question which I have perhaps replied in a different way. This can only be achievable when an integrated approach is there, and not by the bureaucrats alone, not by the doctors or the scientists or the environmental advocates, with everyone. And also, we need to take the public also at large, representative of public in a capacity, so that the smart regulation which has been propounded by the our concerned authorities, and also the under the stewardship of the government of the day, that is possible. It is also possible. It is also possible. The smart regulation is also, of course, as of now, it looks like an academic approach, but it is possible. We need to do a lot of brainstorming on innovation, improving our compliance. That is the main things, which we do not generally focus on, which Dr. Reddy has pointed out, right? I mean, that knowledge we have nowadays, while interacting with the people, with the scientists, the doctors, we have some knowledge, some understanding, and of course, above all, Google we have. But understanding we may not have. Understanding will come from the experience, either in the form of the direct interaction in the as a study curriculum, what Dr. Ranjan also says, and Dr. Ma'am Sonal also said so. So it is a composite approach, and this smart regulation is not enough to understand that yes, you just take out in any other act you take on, then this is not, it's not that. Is composite things, long-term thing for a sustainable future. And if we see, I'll share with you later side sometime, that Newton Wawa Fund, which has projected the UK Economic Research Council and the Government of India project. This has come out with this smart regulation thing, and it is still, we are yet to achieve that threshold level of being a safer AMR compliance country. Thank you all. If I can hand over now.
So there is another question.
Yeah.
I may read that by Rajiv Patil sir. Have the AMR efforts have been pushed on the back burner because of the increased focus on NCDs?
Increase focus on?
It's in the Q&A section.
Okay.
NCDs.
Okay.
Anyone can answer
Yeah, anyone can answer it.
Non-communicable diseases is what they're asking.
Achha, non-communicable diseases. Yeah, I think this is more
yes.
technical. Perhaps Dr. Reddy, Dr. Sonal can do some good work on it. If you can
Yeah,
throw
Dr.
some.
Sonal, maybe you want to take a shot at it. Probably you are
Okay.
better at it.
So I don't think any focus. See, it's a very linked process. Diabetes predisposes to infections. Infections would require antibiotics, and again, antibiotic resistance will require. If there is AMR, it will require higher antibiotic, and the cycle will go on. And then when there is an infection, the sugar will rise, and then the control of NCD will become again important. So it's a complete vicious circle. Health is never done in silos. It is always in a cycle, and everything comes back. So the focus of the governments, whether it is on NCD or it is on AMR, I don't think there is a lack of focus by the government anywhere on AMR. It is us, medical practitioners, the pharma industry, and the general public who has to wake up to this. So
I
would you
will,
like to add anything?
True.
I would like to just add one point. Yes, to some extent, for last about 1.5 decades. Maybe because we are rather influenced by the global north, especially North America. There had been a disproportionate kind of spending on NCDs. We need to be mindful. The countries like India, the countries who are in Asia and Africa, who are still developing, we still have a very large burden of communicable diseases. Even today, in our global south, we have the diarrheal diseases, the waterborne infections. Actually, they are still far higher than the developed countries. So we should not neglect, or we should not actually lose the focus on communicable diseases while we are addressing the NCDs. NCDs, I am not saying that they are not a problem. With our change in the lifestyle, with food habits, with many other Western practices we are taking up in our daily life, definitely NCDs are becoming a big problem. Mental health is also becoming a big problem. But at the same time, we need to recognize that the communicable diseases still are a large problem for a country like India and the global south. Thank you very much.
True. In fact, that's the problem. That see, ultimately, you go back to the drugs, right? Antibiotic, you call it, and that is the AMR is part of show. So that effluent standard, either in the pharmaceutical levels, I mean manufacturing levels or formulation levels, that industry actually needs to be monitored very, very well. And that is what the lack of the environmental laws is, that they do not include the standards for discharge of the antibiotic residues. So that is something which is larger issue. With thanks note to everyone. Now, Dr. Soumya and Mr. Sachin Gaur, you please conclude the meeting today from the InnovatorCLUB.
Yeah,
Thank you, sir. Thank
Soumya,
you.
Dr. Soumya, before you move, I think Dr. Vikash has raised his hand. I think he just wanted to make one final comment, and then you can take over. Thank you. Thank you, Ravin sir.
Thank you. Go ahead.
I just wanted to put one comment that the problem of mixopathy, people practicing in other scientific part like allopathy, Ayurvedic, homeopathy, they are also they have also started prescribing the antibiotics, adding 2 drugs of their own practice and 1 drug from the allopathy. So this problem came when I was practicing in Ministry of Health. This was the problem, and there was a draft which was discussed very heavily. The problem of mixopathy. So this also needs to be taken care of. Second, the One Health. One Health means one health for all. Means from the veterinary to the for all the sections of the medical science has to be taken care of. So the course should include for all the people. The course should include the relevant section for the people working in Ayurvedic, people working in homeopathy. Their course should also include the problem of AMR, the problem of antibiotics. So I'm using unconditional antibiotics. So this to be included in their course also. So it's not that only the medical science people who are in proper that should be only the channel. That's the only 2 points that I want to put in.
Yeah, that is what you call it as a mixopathy, and then as per law, we know it as a crosspathy. Right.
Yeah.
And that is what Supreme Court has recently passed an order on this. But we have already the drugs and cosmetic rules 1995 that which regulates that RMPs. So
yes, sir.
That will take care of it. I hope so.
Yes, sir. Yeah.
Thank you.
Thank
Let
you
us
so
go for one health, one law, and one environment. Thank you.
Thank you so much.
Thank you, sir. So, thank you, Manjunath sir and our esteemed panelists for that engaging discussion. As we come to close our meeting, I would like to extend a heartfelt vote of thanks. Firstly, I express our deepest gratitude to our keynote speakers, Ms. Jasmine Kaur and Advocate Ravin Majumdar, for their invaluable insights. Your contribution are instrumental in driving forward the conversation of antimicrobial resistance. To our panelists, Dr. Ranga Reddy Bari, Dr. Sonal Saxena, and Dr. Vikas Ranjan, thank you for sharing your expertise and engaging in such a thought-provoking discussion. Special thank you to Mr. Sachin Kaur for setting the tone for today's meeting and the InnovatorCLUB team for organizing the event. Lastly, I thank all the attendees for your participation and thoughtful questions. Your engagement is what makes this meeting so impactful. Let's continue to work together to address antimicrobial resistance holistically, leveraging innovation in policy, diagnostic, education, and equity. Thank you and have a great day.